join the group of Ender'S of India. I don't know how many of you are here, but if you see the results of modified technique, I'm sure probably you will forget DHS, PFN and PFN A2. So also humerus interlock nail or plating or even tibia interlock nailing. So I started doing Ender'S nailing for the tibia as well as the humerus also. And if we get a time, we will have those cases for the demonstration also. So we have total 4 cases. One is IT fracture, second is subtrop fracture, third is fractured tibia. Finish in the time. After 2 lectures, we are going to have a short inaugurations followed by delicious lunch. And after that, probably we'll have at least 2 cases in the afternoon. Thank you very much for the patience hearing. I hand over mic to Bhumika.
Thank you, Mahali sir.
Let's start the first half of the session. I would like to call coordinators, Dr. Zinde sir and Dr. Mahajan sir on stage. Now I would like to request Dr. Mahajan sir to introduce our speaker for today, Dr. Jetwa sir.
It is my proud privilege to introduce Professor Dr. Jetwa. Actually, modified Ender'S nailing, he is called as the pioneer because as Dr. Mahale said, there are lots of complications or some difficulties in Ender'S nailing, and he was the pioneer in modifying that. So, I'll introduce Dr. Jetwa. He is the professor of the Department of Orthopedics at Narendra Modi Medical College at Ahmedabad. His He's practicing in Ahmedabad since 1984, and he's recognized and qualified faculty for the NTMC National Trauma Management course and Emergency Medical Technicians course. He's a chief medical researcher and advisor of drug-eluting orthopedic implants. Next slide. So he has so many accolades on his name. He's contributed to most results-oriented and rewarding modifications in implants and its techniques. He has awarded PS Mandal Orthopedic Gold Medal for research in innovative implants of Indian Orthopedic Association. He's developed the first Windows-based medical practice software in 1996. He has got different accolades, and he has got best paper prize of osteosynthesis by epoxy resin also. Next, please. He is honored for the past, he is a past trauma director of the orthopedic department of SL Hospital, Ahmedabad. He is past medical director, Xavier Medical Multi-Speciality Tertiary Care Hospital, Ahmedabad. He is the post medical director of Ashka Multi-Speciality Tertiary Care Hospital. He is past president of Ahmedabad Orthopedic Society. He is past president and secretary of Gujarat Orthopedic Association. He is past executive committee member of IOA. He is chairman of IT and web committee of the IOA and council member of the yearbook of osteoporosis to be published by the Indian Orthopedic Association. Here, we know Dr. Jetwa for his modified Ender'S nailing, and we all have come together to just to listen him. This is here to Dr. Jetwa, please. Thank you.
Uh, Thank you very much for these kind words and so much of uh, good words as well as so much of enthusiasm you people have on Sunday to learn something which you have just started developing and getting good results. And what we do now is we are going to talk about the two cases which are going to go with the live surgery. So just can we project the first case? So now here is the case where we can see 80-year-old female has got a history of fall, becoming casualty, and there is a fracture of the left intertrochanteric region. Now what we do is, usually such cases where there is a subtrochanteric variety, which is, it looks like an intertrochanteric, but on the medial side if you see, it is going a little bit lower, and the lesser trochanter also is broken, so it may be unstable variety. Now in all these cases, what we look for first is that what is the superior border of the opposite side of the neck. Whole superior border of the neck with the tip of the trochanter. Compared to that, on the other side, we know that it has been rotated. Most of probably it is rotated anteriorly and in axial rotation. Now, once we understand any case where could be the displacement of the fractured fragments, then probably it will be easy for us to decide how can we reduce. There are so many cases where we are still not able to find out the morphology of the fracture, so now we advocate that all cases of IT we should go for a CT scan. The CT scan will tell you the some of the fragments which are more on the posterior side, posterolateral, posteromedial side, which you might miss. Say for example, if the posterior wall of the neck is deficient, those are the cases which cannot be fixed by any of the method. You might have to go for primary calcar bearing replacement. So CT scan sometimes gives you a better confidence and understanding of the fracture morphology. The second part is that how will you reduce? Because forget about which method you are going to fix. Reduction is the prime part. So in this case we know we need to derotate the proximal fragment. Okay. After good reduction, yes, we have so many various, implants assembly which we are using. Now can anybody tell me that what could be the problem with PFN in this case? Is there anything which we can think of? We are doing it and we are getting good results also, but sometimes we are not able to derotate. The only problem in cases like this is a wide medullary canal, and PFN cannot be set that much thick. So unless you use a lone PFN which has got a good hole distally, the whole PFN will be moving inside, and that is the real problem with such cases. And that's why sometimes there is some failure, sometimes it is not a good but there are cases where all methods can be applied. It is not like we have to stick to one method. But all cases, all methods when you apply, in all methods we need a good reduction. So in this case we are thinking that we'll be derotating the proximal fragment, we'll passing 2 or 3 Ender'S from below and one from the lateral side, or maybe we'll be passing one from the trochanteric tip. Now here we know that all these cases of intertrochanteric fractures, they are externally rotated. So the shaft which you are looking is a lateral view of the shaft. It is not the AP view of the shaft. So by that we know that how much is the roomy canal. There are cases, young cases, where the canal is very narrow. We might not be able to pass 3 nails. In those cases we have to be little bit skeptical. We have to be little bit cautious that should we go with ender nail or not. In a young adult with a long bones, we require 3 nails. And if the canal is so narrow, better we think of some other methodology. So it is not like we pick up one and forget other methods. We try to see that which is minimal invasive. Like all methods can be used, then which is the best, which is minimal invasive, where we just do not disturb any muscle attachment. And we get the good reduction as well as the good outcome at the end. And that is how we pick up for this. So this is the one case. In a lateral view, we can see that there is quite a good amount of angulation. And let's see how we can get a reduction, and we'll put an ender nail. We might not put CC screw unless it is required in the lateral wall, which is 2 below. We'll see after the reduction. It is a good practice that you keep all this methodology ready on table, because all wisdom starts after reduction. So when you look at the table, when you just reduce it, you look at the IITV, then you realize more, okay, this probably seems like can be fixed well with the DHS or angle build plate or PFN or whatever. So that is a very important part, that you have a good study of the fracture morphology after the reduction. And the second case, we just go with the second case. The second case we are going to pick up is a distal tibia. And here you see the patient is having a significant osteoporosis. There is a very thin fibular fracture which is just above the tibiofibular ligament, which is a stable syndesmosis. So we might think of fixing only the tibia. Now the tibia, if you look at on the medial side, there is a possibility of continuing the medial cortex. But on the laterals, on the lateral side it is continuing, but on the medial side there is probably a butterfly fragment. So our aim would be to see that how can we restore the fixing the fibula, and if we cannot fix the fibula, then at least keeping one continuity of the one cortices that can give a length. So that is how we think, and there is a second case we are going to take it. So now I'll just ask Dr. Vipul to go upstairs. So we start that, and meanwhile I am just finishing the first lecture of intertrochanteric from my laptop, and maybe in 20 minutes till he starts, and then I'll join him, and then we people will be having many questions during the surgery as well, right? So can we switch over to this? So once again, I thank you very much, all colleagues, seniors, and Dr. Mahale, Dr. Sriram, all those who has given so much of an push to our new modification and technology. And I wish that I should be able to clear all your queries. So do not hesitate in asking anything during whole day, so that we'll be more than satisfied and we'll be having a good sharing and discussion for all those cases. So it is a happy fixation. The word which I have come out is called happy fixation. So we know that everything is fine when it is a two-part fracture. So it's not like it's not working. Two-part fracture, anything you do is good. There is a good continuity, good reduction, good bone stock. Patient is compliant, and then you can allow them to weight bear whatever the method used. The problem starts with when it is a 3-part or 4-part unstable variety. If it is not done well, it is going to go with a failure. It may be even ender nail, because those ender nails which are not properly placed or in the conventional old method, we used to have similar kind of complications. So what is the challenge? In a modified ender nail, we are using nails with specific counters plus CC screws, calibrated cancellous screw of 7 mm. So what I'm going to talk about all these assemblies and how the people have come out with these modifications, and what are the comparable features with the other implants, operative steps and illustrations, and some of the new terminologies, some illustrations of the subtrochanteric fracture, complications, and the word which we have coined happy fixation. What do we mean by that? The first thing is comes the property. Many times the whole life is gone and the orthopedic center do not know that there is another alloy which is there in the armatorium. It is not simple 316 LVM. It is an alloy which has got a special elastic alloy. It is stable in autoclaving, is as elastic as bone, and up to 20% it can regain the bending. So it is basically a process annihilation which makes this metal more elastic. Plus we are using 7 mm CC screw U-clip which is made up from 1.8 mm K wire. There were some experiments we have done with a serrated clip, but all these which are additional, they are LVM 316. It is not the other matter. Now this we all know, when there is a bunch of sticks it's difficult to break. Individual stick you can break, and that is how multiple nails is not going to break that easily. The simple principle which has been studied in 1986. In Japan in 2002 they said that it is easier, faster and earlier in large callus they have observed, and it promotes the callus formation. So developed countries also have their own say. Now Kemp says that whatever the type of pertrochanteric fracture, the synthesis brought out by Ender'S lead to a large majority of cases of a solid fixing. He said it is a solid fixing, and why we don't get it, because probably we do not go into the details of the biomechanics. But this is one of the best publication where 2,137 cases of Ender'S, not a single case of broken nails, not a single case of non-union. And how can we avoid such publications? We need to think of what they had done before and why it is still not that much in use. So we thought of that there were complications are encountered, and so we started understanding the drawbacks, discussed the problems, and then successfully we could add some modifications in the technique. And this is what today we are going to have this humble sharing. In the classification we know that in intraorgan fracture if the pre-reduction is stable or post-reduction is stable, go with anything, all conventional things are okay. But in case where pre-reduction is unstable, try to do a good reduction. And after reduction if it becomes stable, again you can go with multiple choices. But in case of a pre-reduction which is unstable, post-reduction also unstable, then probably you need something where it can reshape, it can recreate the actual anatomy of femur, three-dimensional, spatial, like the lower part is here, the upper part is anteverted with neck shaft angle. So in three-dimensional, if you can recreate, that is what Ender does, and that is how there is a difference. So the mechanobiological challenge in fixing unstable intertrochanteric fracture is the key part. This is what we see in our day-to-day in our wards, that there are challenges with intertrochanteric fracture, and the challenge is that we need to have a best of the reduction, particularly anteromedial border, neck shaft angle, anteversion. Then we have to have something to fix the proximal fragment, something to fix with the distal fragment, and something to join both of them. That sort of an implant we need. And at the same time we need control collapsibility. Why? Because there is always inherent some sort of a cells near the fracture line. They die, and so there is some gap which requires some collapse. So collapsible implants, yes, scientifically we say no, we want a complete length, we do not want 1 mm of shortening also, but that is possible in younger patient. In older patient there would be some. So we need a collapsible implant which enhances the reduction. And all on that, what is the biggest complexity is osteoporosis. So this is the basic thing which you are trying to target. Now if you go with any of the classification, you know what is the constant in interorgan fractures. The constant thing is a proximal side there is always intact head and neck, and the distal side there is always intact subtrochanteric region, maybe little distal to that. Now this is what is targeted with the ender nail. So what we do is, after a good reduction, which you can see on in the inside there is a good reduction which has been achieved, you try to hold something proximally, try to hold something distally, and the job is done. Why? Because it is the only ender nail which can be truly anti-verted. So anti-version is from the center of the medullary canal, and that is how you are able to do with these three things only: superior hold, distal hold, and then a proper bending and proper contouring of the nail. So elements of biological smart fiction is a smart techniques which so many of our stalwarts, our colleagues, uh, Dr. Shiv Shankar has so many good videos of showing how to do a good reduction of intertrochanteric fractures. So all these things you have to learn. There is a 7 mm interfragmentary screw which we fix first. Now think of, if I have a good reduction, if I pass one interfragmentary screw, can there be external rotation deformity? There cannot be, because it is very well fixed in a proper rotation. So whatever happens afterwards is because of the externally rotated reduction rather than externally rotated link. So here we take care of with the first interfragmentary screw, then 3 contour nail one by one, and at the end another 7 mm turbo screw. Just after a few slides I will tell you what is turbo screw, and at the end we go with a distal U pin. And my senior colleague, my teacher Dr. Rohit Shah, he added this CC screw. He thought once that why not to put CC screw to see that can we enhance the fixation, and it has worked. Although we have come out with a turbo screw effect afterwards, but it was originally it was thought by Dr. Rohit Shah. Now our Indian Journal of Orthopedic has published this, that what is the square area which has been fixed by all different implants, which is from 20 to 37%. But when you think of ender nail plus CC, it goes up to 54%. So larger, wider area is captured in head and neck. And that is the advantage of using 3 nails plus 2 screws. And graphically, if you see on a 2D surface, the area which is captured by all these implants, the ender nail is much wider. So probably it's going to have a better fixation, especially of the proximal fragment. One more thing which happens is that when you go on passing these implants into the neck, it goes on displacing the medulla. So after passing 5 elements into the neck becomes very strong, dense medulla happens. It's like impact bone grafting. And that is how it does not lose the hold. So all those cases where there is a Varro's collapse will not happen, because it is the neck which has been fixed. So this modification is not only the technique, modification in the understanding, modification in the principle, that rather than fixing the head, we are fixing the neck. So TAD is not very important in ender nail. Yes, it is important for the CC screw we are passing, but the ender nail may be preferably with a good TAD, but it may be little shorter, because we are crowding, or rather filling up the neck region. So with the neck region it is filled up, it is not going to give way or rotate. None of the implants is anti-verted, as it is ender nail. You can very well think of that this is a imaginary picture where there is no anti-version, no anti-torsion. Look at the lateral border of the trochanter. Here you can see the tip of the trochanter is also had gone down, it is not lateral, so it is anti-torsion. Anti-torsion means the whole of the proximal femur is rotated. So what is anti-version? Anti-version is where the lateral tip of the trochanter remains in the same place. It is from the intertrochanteric ridge it starts getting anti-verted. So if you want like this anti-version, what can you do? There is a fracture, and if I put the screw like this, it will go into the posterior quadrant. So I need to have a screw like this, which is not possible. Not possible to manufacture, not possible to pass through the DHS. So much in the similar way, PFN, this screw will be more on the posterior side. If I want a true anti-version, I need to have such screw, which is not possible. And that is the reason why we need something which starts from the base. So sometimes we try to rotate it and put it, but if there is a posterolateral slit, then it will go through the slit, if it is not an intact posterolateral aspect of the proximal femur. So here CC screw can be passed from anywhere. You need not go. Whatever is the intake area in the anterior part, anterolateral part, you can pass through. Then 3 specially contoured nails, and the fifth one is the turbo screw. So that is how the whole problem of lateral wall is solved out, because you are fixing in a 3-dimensional way head and in 3-dimensional way the lower shaft. In between you forget, because it is not in the same plane, it is anti-verted with a neck shaft angle, and that is how it works. The principle is something which we see on the railway track line when there is a clamp which is like this. So these nails which we are bending anti-version proximally and posterior bend distally works like a hook. So that hook will keep the railway track absolutely stuck to the ground, much in the same way. When I show you during surgery, you will be able to appreciate that what I am thinking about, I am trying to explain about. So nail is not like simply going straight. Inside proximally, it is touching inside of the anterior dome, anterior inside of the head. And distally outside the femur, it is touching the medial condyle of the femur, and that is why there is a hook. Now with this hook, there is no possibility of extra rotation, because hook is such that it will not allow. So turbo screw is something where at the end you pass a screw to disturb already placed ender nails. So how do we disturb? You just push the screw. When you push it, the nail has to bend. Either tip has to bend or the 2 nails have to go apart. So what happens? They are going to get displaced. The original path is displaced, so they will have a better hold, and that will not allow it to draw back, back out. So this is how you are disturbing the path inside of the head, and that is which is called as a turbo screw, which is targeting between the 2 nails or maybe the tip of the nails, and that is how it works. So here you can see, look at this in both AP and lateral view. You see, it is simply touching one of the nails or maybe between the 2 nails in the lateral view. So it is disturbing, and then it is having a more side to side pressure with a better hold on the proximal side. Now what are the problems now people are coming out? When the diclofenac was there, people will say diclofenac good. When aceclofenac comes, then they start talking about what is bad about diclofenac. So the same way, now we know that proximal femoral entry is very, very much injurious. It is killing so many things. An injury to muscles and their attachments. So much so there are a number of publications which say up to 53% of the cases there is a substantial injury with some hip pain. So we can think of how can we avoid proximal femoral entry, and in Ender'S we do not have that. And there is also a concept of barred spot, which is the area of the trochanter where there are no attachments, where we can pass an implant. It's a very small area. And so whatever you put implant, particularly on the lateral side, is going to take up some area of attachment of the muscles. So what we need is, do not touch that. Do from the medullary side, and only a small screws which can just disturb the lateral. So this is what is not in case of Ender'S. So now, just to sum up, the old problem where external rotation, weak fixation, distal backouts, proximal cutouts all have been solved by fanning, elastic hook, U-clip, turbo screw. All those things have helped us a lot. So I just finish up with the operative steps, and I might now go upstairs, and then I have a couple of cases also afterwards. In between, if there is a time, we'll go through those cases. So what is the pre-operative surgical workup? Pelvis with both hips, AP, medical fitness, CT scan, very important, instrument set, implant set, and alternate fixation set. we are not married with ender nail. We have to keep everything ready and see that what can you do the best for the patients. So these are the instruments which you will see during surgery. So there are nails, then there are something to rotate the nails, something to take the entry as an owl, something to bend them, and particularly big parallel plates which can give you anteversion and posterior bend. Typically, in case of a PFN, we keep this IRTV on the middle of the legs. Here we put the IRTV outside toward the head region, so that initially we can pass some interfragmentary screw or derotate the proximal fragment. So here you can see the position of the C-arm and the surgeon. The moment we do primary part reduction and primary interfragmentary fixation or whatever, from the lateral side, then surgeon goes on the medial side, and from there we start the medial distal femoral entry and pass the nails. And this is the typical setup how we can use this. Now, why do we use 7 mm? Why not 6.5? The simple argument is that in 6.5 you are given 2.5 mm guide pin, which is too thin. It does not go into the trajectory where we want. There are epiphyseal scars. It goes on diverting. So once you try to pass this 2.5 mm, it might bend. So what we need, we want a thicker one. So we need a 3.2 mm drill tip pin so that we can go exactly there. In order to use this 3.2 mm drill tip pin, we need a larger screw, a larger lumen of the screw. So larger is not to get a larger hole, the larger screw is to get the larger drill tip pin where you can have a best trajectory. And that is the purpose of using 7 mm now. Up to 8.3 mm CC screws are available in the market. So here there is a patella, there is an adductor tubercle. Likewise, you put an incision on the medial side. You try to see the tibial tuberosity, and the saphenous vein is much posterior. Then after you open up, you have to go subvastus approach, which is as we are getting this in total knee replacement subvastus approach. Much in the similar way, the posterior septum is seen there. Below posterior septum there would be adductor and all those, but above that, the vastus medialis you can just erase and you can go into the bone. There are these vessels which may bleed a lot, which I have shown you on the upper right figure, that you have to cauterize well, otherwise it might bleed a lot. And then according to this figure, at the proximal end of the patella and 1.5 centimeter proximal to that, and on the posterior half of the femur, you may make 3 4.5 or 5 mm holes, and then mix them, make a good fenestration with the awl. And then there is a banding. We have 2 sagittal bands and 3 coronal bands. All these contours are very important. So I have shown you the fresh nail on the left side, then the sagittal bands, and then the coronal contours. So the sagittal bands 1 and 2, each band has its own credit, own role to play. And I have discussed this thing in detail in my YouTube video, but this is very important that you have 5 bands. And each band will be lesser and lesser once you pass second and third nail. The first nail may be more band, and then the second and the third. And this is how you make a posterior band and an anteversion. Look at this. This is possible only with this particular bending instrument. This device, if it is not possible. And then you give a curve with a tip curve. So after the 5 bands, this is how it can be seen in a sagittal plane. So it is the nail which has been contoured in a way which works as a clamp. So this is the band nail, and when it goes inside, then it's going to have a clamp, and that is how it is fixing. And this is how you can see lower down There was an interpigmentary screw, and then this nail has been passed. And then subsequently you pass the second nail, and if you feel like you can put one more drill tip pin superiorly so that the reduction is stable, you complete all the 3 nails, and you need to suture the vastus medialis completely so that no implant is seen there. If you do not do that, then also it's going to give up some problem. So you see that proper bending will keep the nail flush with the bone. At the same time, you cover these so that patient can start knee bending early. Now, at the end, what we do is quite often we pass this U-clip, which is made up of 1.8 mm K-wire with a plier, and then you make a drill hole, maybe 2 nails together or 1 nail and 2 sides, and then you try to push it like this. So at the end there is a pin. Now remember, this pin is not to prevent the backouts only. It looks so logical, so simple. Yes, I put a pin so it should not back out. No, it is a 20% of the aim. 80% is that this clip is going to be an extension of the nail laterally. So if the nail or the distal fragment has to rotate, it has to have wipe out the whole condyle inside. It just cannot. So the nail will not rotate. That is a very important thing, because the clip is side to side. So clip has to go like this. It is not possible. And the second very important mechanical aspect is that at the end, when we see these 3 nails on the medial side and you try to move the knee joint, 3 nails again have an anteroposterior some wobbling. Now this anteroposterior wobbling is also fixed by this clip, and this anteroposterior wobbling is the main cause of Z effect or pushing effects of the back out. So it is what we prevent is the wobbling of the nails, and by preventing wobbling it will not go on sliding down and down. So clip maybe logically it is for the back out. It does back out, but not the simple way. There are biomechanical forces by which it does not allow backing out. And then there are sequences depending on the cases. You might pass the first screw, then nails, or maybe nails first, then screw, depending on. There are cases where you do not do anything, simply pass 3 nails and no CC screw. So all these variations are there. So now I stop here. I'll be going up. Anytime, any questions you have, please go on asking me, and we'll see that how can we go with the first case. Right then. Thank you. Thank you.